Welcome back. One of my hopes for the future of psychiatry is that we're going to be able to come up with treatments which are more specific, more individualized, more precise in helping people with their mental health. And this can, of course, include biological treatments. This is exactly what we're going to be talking about on the podcast today. We're going to be looking at a case study of a 44-year-old man with an alias, Mike. Mike has been suffering lifelong with treatment-resistant depression and was enrolled in a study to try and treat this depression with a new form of brain stimulation called PACE. PACE stands for personalised adaptive cortical electro-stimulation. That doesn't quite roll off the tongue so easily, but we're going to explain it all today. And we're going to explain why this new form of brain stimulation is so exciting. With me to have this conversation is the lead author of this case study, Professor Ziad Nahas. Professor Nahas is the Executive Vice Chair at the Department of Psychiatry and Behavioral Sciences at the University of Minnesota. He's a psychiatrist and researcher who specializes in the treatment of mood disorders like depression and bipolar, and specifically in the use of deep brain stimulation techniques to treat these conditions. He's been running studies using brain stimulation techniques for a long time. This is his latest case study, which has just come out, and it looks at how this personalized adaptive form of brain stimulation can treat something like treatment-resistant depression. Today we go into depth into Mike's case, the specific kinds of difficulties he was experiencing, how this form of brain stimulation works and the procedure that he underwent, how they recorded his brain activity, how they adapted the stimulation specifically to his brain, and what parts of his brain they stimulated. We talk about how he progressed with his treatment, how well he did, whether or not he actually recovered from his depression, and what this treatment may reveal about the biology of depression, which is fascinating. We've had a number of conversations about brain stimulation on the podcast, and I'd like to take this moment to make a distinction between the different kinds of brain stimulation. So if you like, you can go from superficial to deep. We talked to the guys at Flow Neuroscience a couple of months ago. They produce a brain stimulation headset that's more superficial. They're headsets you can use at home. They apply what's called direct current stimulation, so it's a little bit safer, doesn't need as much supervision, generally used for something like mild depression. Then there's something kind of in the middle, like transcranial magnetic stimulation, that uses a machine that you need to access in a clinic under supervision. It's a little bit more intense and can be used perhaps for more severe depression. And then we have the kinds of stimulation techniques we're going to be talking about today, where you actually do an operation, open up the skull, and implant electrodes onto the brain. And these are electrodes which remain active and usable for long periods of time. With that in mind, I hope you get a lot out of today's conversation. I learned a lot. I had to learn a lot to prepare for this conversation, and I definitely learned a lot having it and listening back. One more brief announcement. I was recently on the Examined Life podcast, which I really enjoyed. That's hosted by Kenneth Primrose. And I really like this podcast. It has a nice format where every conversation is centered around the question. For this conversation, the question was, how should we prepare for an increasingly technological future? This is a question I am perplexed by and fascinated by. I enjoy talking to Kenneth about this. I'll put a link to this podcast in the show notes, so you can check it out if you like. In addition, I have a couple of exciting announcements for the new year, which I'm not at liberty to share yet, but I will soon, so stay tuned for that. Otherwise, enjoy today's podcast. If you like the podcast, if you want to support it, do like, follow, or subscribe on whatever platform you're listening on. Share it with a friend who you think will like it. Give us a rating or a review. If we end up on your Spotify Wrapped, don't hesitate to post that on your story, and you can tag us at Thinking Mind on Instagram or at Thinking Mind Pod on Twitter. Thank you for listening to today's episode. Here's our conversation with Professor Ziad Nahas. Professor Nahas, thank you so much for joining us.
Thank you, Alex, for inviting me.
I am so keen to discuss this case study with you, and it is a study looking at a very specific treatment, by the looks of it, a very new treatment, and that's called PACE, which stands for Personalised Adaptive Cortical Electro-stimulation. Having read about it in the research for this podcast, it does seem like something out of science fiction. and wonderful to get the opportunity to learn more about it today. You did this case study looking at a 44-year-old man. His alias was Mike. Could you tell us a bit about what were Mike's problems? What were his difficulties going into the study?
So Mike is someone that currently meets the criteria for recurrent treatment-resistant depression and post-traumatic stress disorders. Mike is in his late 40s. He experienced depression as a teenager, had multiple hospitalization between the age of 20 and 30, including suicide attempt and self-harm. Underwent a series of pharmacological treatment with partial responses, found himself in need to apply for disability and got off the workforce. Initially received electro-convulsive therapy for his severe depression, had a partial response, felt encouraged somehow. So with his sense of duty and ethics, he dropped his disability, attempted to go back to the workforce, realized that he couldn't do it, went back on disability for the second time. In the meantime, he tried ECT twice since that first attempt, and whereas in the first round he received some partial response, he didn't really respond at all to the two other courses of ECT. And it's culminated to a level of depression and hopelessness that he had a very serious suicide attempt. He was discovered accidentally by a sheriff, him in his car, unconscious, trying to asphyxiate himself with a carbon monoxide, but also having ingested hypnotics. And so it was a fortuitous discovery that got him into the hospital, and eventually he lived. He approached us about this study almost a year before we actually enrolled him. At the time, we were still trying to figure out the logistics and resources to pull it up. And he showed, honestly, a great intentionality. He knew his options. They were limited, but nevertheless, he still had options. And he wanted to pursue and wait until we got our act together, ready to actually implant him. And we managed to obtain almost a year-long baseline assessment.
You had a year of his baseline mood, baseline mental state.
Exactly. And ultimately, he took a leap of faith. When we had asked him one of the scales we actually have in the study is expectations of response, and his were a 30%, meaning that at best I'm going to get a little bit better. And so that gives you a sense of some hope. Obviously, it's hard to imagine that somebody is getting ready to have brain surgery for their depression wouldn't have some hope to take such a leap of faith. But it's also minimal compared to ultimately what he ended up experiencing as a life-changing treatment.
And I think I read that he had tried some 19 different antidepressants. Is that right?
Correct. I mean, he really, part of those particular type of research is in severe treatment-resistant depression is it becomes really very important to do the proper homework in assessing the level of severity, but also of severity of the symptom at the presentation, but also the number of treatment that have not worked for you. And there's a big distinction that I think is very important for patient in general. Oftentimes I see patients not to the severity of Mike's and certainly not necessarily candidate for brain surgery because a lot of stuff haven't been tried out to treat their depressive symptoms. Patients need to distinguish between taking a medication, experiencing some side effect. I'm getting nauseous. I couldn't handle it. I stopped it after 2 weeks versus really taking the dose at the high enough milligram equivalent and then long enough, at least 4 to 6 weeks before you say this medication didn't work for me.
So you're making the distinction between ineffectiveness of the medication versus too many side effects?
Too many. So if they're having side effects and cannot take it anymore, it's true. It's no longer an option for them. And so in that respect, that's a medication that is likely not to be tried again. However, it doesn't predetermine their likelihood of responding to the next treatment, because historically in treatment depression, the more you've truly failed treatment coming into this current treatment, the less likely you're going to respond to it, right? And so doing that exact homework becomes really important.
Yes, and I would like to point out for the listeners that even though this does sound like quite a severe case of treatment-resistant depression, it is more common than you might think, and it's something I've encountered a lot. There is a national service set up in the UK specifically aimed at treating people with treatment-resistant depression. But even in a local community mental health team in London, you would expect to see patients pretty similar to Mike reasonably often. So treatment-resistant depression really is quite a big deal, and it affects a lot of people.
It is a big deal, Alex. And as a clinician as well, over the last 20 years, I've also witnessed a worsening of the TRD presentation. I am involved in other brain stimulation research, for instance, vagus nerve stimulation. When we first tested it out, the first case to be ever implanted for depression was in 1998. It was in a lab where I was in Charleston, South Carolina. The average number of failed treatment in a current depressive episode was about 4. Fast forward 25 years to now with the RECOVER trial that is sponsored by Livanova, where they studied 500 unipolar patients. The average number of failed treatment lifetime is 13. So it gives you a sense that over decades, 2 decades, we are witnessing a substantial worsening of the TRD presentation. And it begs the answer as to what is it that we as clinicians might be doing wrong to contribute iatrogenically to this. It's not an anti-psychiatry statement. I'm clearly a psychiatrist and I'm from within. But I think we need to be mindful that sometimes our medication may modulate plasticity. And plasticity is the idea that the more you push synapses to communicate to each other, the stronger that relationship is. People seem to associate plasticity to something positive, but in fact, it's just a fact, right? It's more connection, and it could be positive or negative. And so if you are not specifically addressing underlying reason behind a depression, not teaching someone new coping skills, and yet giving them a suboptimal antidepressant drug that could be modulating plasticity, you would worry that it's not only not effective to treating the symptoms, but you have to wonder to what extent it's actually perpetuating poor coping skills, because now those connections are becoming stronger by virtue of taking that drug. And so it's a very hard scientific question to truly investigate. If I wanted to write one paper that really would be the focus is how could we go about understanding that? Because the other fundamental thing that has happened primarily since the mid-'80s, early '90s, when we started having very safe and often tolerable antidepressant drugs, is that we have lowered the threshold quite a bit in administering those drugs. And as you probably know, there's a number of studies that shows that if you have mild to moderate depressive symptoms, the antidepressant drug is really not better than placebo, and it's only start working when it was in the moderate to severe symptoms. And so a careful prescribing habit to these patients an increased utilization of evidence-based psychotherapy are not are needed, and we as much as we're talking sci-fi today, there are certain basic principles, I think, for the general community to hear and to rethink. If one of your listeners is depressed, taking antidepressant, to be able to understand fundamentally what that is and what else should they be doing to optimize that treatment, as opposed to passively just taking the drug itself.
Right. Certainly the idea that there's a large population of people with mild to moderate depression, and we seem to be leaning too hard on drugs. Not that drugs can't be useful, but we may be leaning too hard on drugs and not leaning hard enough on psychological approaches, teaching better coping strategies, helping people deal with stress. We've made the argument for making certain societal change on this podcast, help actually make people's lives a little bit easier and hopefully a bit less stressful. These are all topics very dear to our heart on the podcast, so I'm glad you brought them up. Getting back to this case study and PACE. So we've heard about Mike, and he's a 44-year-old man who's had, sounds like, pretty severe treatment-resistant depression for a long time. What is the treatment that he underwent with yourselves?
To transition a little bit from medication to brain stimulation, I think the way people might be able to better conceptualize the fundamental differences is that with drugs, you are introducing an exogenous compound to the system to modulate it. With brain stimulation, you're banking on the endogenous property of the system to respond. Because at the end of the day, with brain stimulation, you're either going to depolarize a neuron or you're not. And whatever you're mustering as a neuronal response or an orchestrated network response is really from within that system, as opposed to an exogenous compound coming into it. So that's, I think, is a crucial, important fact. So when we were conceptually thinking about this study, and mind you, my preliminary work leading to what I call now PACE, or prefrontal cortical stimulation 2.0, was the 1.0 version of it, which I had done in Charleston a couple of decades earlier, where now I'm at the University of Minnesota. The idea being is that depression is a heterogeneous presentation, right? If you look at the DSM criteria, you have 8 listed. You need to choose a combination of 5 out of 8 in order to make a diagnosis and make sure they've been lasting for 2 weeks. I don't know how good you are in math, but a combination of 5 to 8 is certainly a lot. And so you can imagine that there can be multiple subtypes of depression that we are lumping under one particular umbrella, calling it unipolar depression. And back early in 2000, we had begun making really sensible gains in understanding the functional neuroanatomy of mood dysregulation. And whereas there were key target areas, people were targeting the dorsolateral prefrontal cortex, which is that front part of the brain on the left side, to treat it with transcranial magnetic stimulation, or people are targeting deep into the brain structure, the subgenual cingulate, to treat it with deep brain stimulation. I argued that given how little we know about the pathophysiology of depression, truly know, and the heterogeneity of the symptoms, why don't we approach treatment with multi-target stimulation, so that, roughly speaking, the lateral networks, the networks that are typically on the lateral side of the brain, are the one that most likely you and I are currently utilizing the most by engaging, being attentive. I'm paying attention to your question, you're listening to my responses and formulating come back. So that is very much engaging the lateral network. Whereas if you were to introspect, think about yourself, think about yourself in relationship to others, that is the medial networks. And so for a depressed patient who may be getting overwhelmed if you tell them plan 2 days in advance for a task you're about to engage in, that's really a failing of the lateral networks. Whereas their emotional pain, their social isolation, their inability to feel emotions even to their closest relatives, their kids, their spouse, that is a failing of the medial network. And so why don't we modulate both complementary network at the same time? And that's what we originally did 20 years ago. So we implanted 4 paddles, long kind of rectangular shape with contact electrodes on them. And whereas they're typically placed on the surface of the spinal cord to treat pain or other condition, we've appropriated them to place them intracranially, so inside the skull, never through the brain tissue, but laying them on the surface of the cortex. And we placed those paddles onto these regions and reported that 3 out of 5 patients achieved remission within 7 months, and that was sustained till 5 years. So that was the original. Whereas with Mike, we wanted to catch on to 21st century kind of advances and really take it to the next level, which is the sci-fi part you were talking about. Can we truly individualize our approach so that we can get better outcome? And if we don't have the full understanding of how depression come about and how depression is biologically sustained, let's utilize the patient's own responses as a guide, in addition to obviously the theoretical knowledge we're coming in terms of this area does this and this area does that. And so with personalized and adaptive cortical electro-stimulation PACE, there's 2 key components here, and I'm going to try to break them down. The personalized part. The personalized part is really coming in terms of where are we going to stimulate? We already agreed we're going to go with multiple target because depression is heterogeneous and there may be psychomotor slowing, but also emotional pain, but anxiety, etc. So we know there are a plethora of symptoms and we want a multi-target. And so we are taking advantage of great advancement in functional neuroimaging, whereby you could take a resting state functional MRI. So this is not just looking at the structure of the brain. This is trying to give you a sense
how the brain is working in real time.
And whereas a lot of people have utilized this technique, but acquired data for, 6, 8, 10 minutes long, it turned out that when you're acquiring this length of data, you have a huge variability within the data, right? Data in general inherently is noisy. And so all you could do with this type of scan is do a group statement. In general, on average, this is the brain activity when engaging in doing X, or is this. If you scan up to an hour long, all of a sudden, because you're acquiring more data, your variance, that variability, the noise in your data is going to become less. It'll never go away, but it'll become really much less than it would be if you were acquiring 10 minutes of data. And that turned out a really important element to be able to make individual statement on the topography of these different functional network in the brain, and to be rather millimeter precise in the borders, let's say, between a network that is really important in executive control versus a network that may be really scanning the environment and your internal state to look for red flags, where you need to pay extra attention and consequently act on it or divert emotional energy towards solving a problem. And so that is allowing us now to take Mike, put him in a scanner, and when we're looking at his brain, be able to identify these different functional network. And we mentioned, I'm going to repeat the word complementary network, because each one of them is doing somewhat different, and yet they're all in cohesion, so to speak, to present you as a full functioning person. And so we were able to identify that. And I want to come back to how unusually abnormal his brain functional anatomy was, but I'll come back to that in a second. So that's the personalized part. But we know in brain stimulation, the parameters to use to engage those neurons is wide open. You can stimulate 1 pulse per second, like a 1 hertz, or you can stimulate 120 hertz and anything in between. You can give a train of stimulation a few seconds and pause, or you can give it continuously. You can change how fat each electrical pulse is. That's the pulse width. You can change the amplitude of the stimulus itself. That's the intensity of the stimulation. So you can see the choices can really be overwhelming. In drug therapy, we have milligram to worry about. And if we're lucky, we have medication like nortriptyline, where we can take a blood level and get the minimum blood level you need to be effective, but also the maximum by which you're not gaining any more and you're only getting side effects. In brain stimulation, the choices are substantially more. And so the adaptive part of the study is essentially taking the feedback from the patient, their preference of the setting they've just been exposed to, and pairing it against another 4 or 5 choices, and let the patient experience those at home. They toggle through those settings. They don't know exactly what they're getting. We are assigning those by setting 1, 2, 3, 4, 5. So they're masked to the parameters they likely are getting. And yet they're giving us daily report on their mood, on their quality of sleep, the number of hours of sleep, and critically, their rank ordering. I like this one substantially more than I like the other one. They come in the following month. We carry over the best setting, but we're now exploring yet 4 or 5 other new settings. And we do that iteratively 6 times in the first 6 months of the study, until we have identified what seemingly is the preferred setting for this one particular patient out of those million of parameters options that otherwise we would be just picking out of a hat. We keep those settings fixed, and we say, okay, now we're no longer changing those settings, and we're going to hold them on the same from month 7 to 12 from the time you got implanted. And we're going to call our primary outcome measure, did this work? Are your clinical symptoms substantially improved at a 1-year mark? So the first 6 months are optimal targeting, but also optimal search for the right parameters to use for this one particular individual. And the next 6 months is really testing it out a little bit longer, because there's something about chronic stimulation, especially in my book, where we're giving intermittent stimulation as opposed to continuous, like is done with Parkinson's disease and deep brain stimulation, for instance, where the effect can have an acute modulation, and that's what we described in our paper, immediate change in attention, immediate clarity in the visual that I'm seeing and the colors and how vivid and crisp things are, as opposed to having a foggy brain, right? But those don't necessarily translate to an immediate antidepressant effect. The patient is still depressed when you're considering the totality of their presentation. They are, however, experiencing these kind of unique, immediate responses to us switching stimulation parameter. Over time, however, Mike began also to improve clinically and manage to almost get remission by 6 months, not quite. And remission is, by definition, absence of depressive symptoms, really, as opposed to somewhat improved or greatly improved. And yet reached ultimately that threshold at 9 months, lost it at 12 just because the few days before he contracted COVID and lost on his rating scales a couple of points on sleep and energy, as understandable. But that's how research work goes. And then since then, he has been in full remission. And now I just saw him 2 weeks ago, actually last week, and I believe we were at month 39 from his first enrollment. So he's been 2.5 years, essentially, in a full remission, something that he had not experienced the prior 30 years.
Wow. How long did it take for him to begin to feel his mood lift, for him to begin to feel a bit less depressed after the devices were implanted?
We tested him first in the ICU to be able to just test out our own hypotheses. If we are stimulating executive control, are we really seeing more attention and focus, or if we're stimulating? And this is where we were able to elicit that positive emotional response by stimulating his default network that surprised us, but clearly surprised him. But as I mentioned, he was obviously clearly still depressed, but that kind of got it in his brain that, oh, it is biologically active. I am experiencing something.
It is possible to feel better.
And I'm sure that that contributed to a sense of hopefulness. His first 2-3 months, and remember, we were asking him to change the settings every so often, every 3 days. We gave him the option, if you change the setting and really don't like it, just don't force yourself to stay at the 3 days. Just let us know and move on to the next setting. He found those actually quite stressful, because if he liked a setting or he felt somewhat relieved, his anxiety may be reduced, he would be apprehensive. Okay, I'm switching to a different setting. What if I'm going to lose that little bit of positivity that I gained? And so that actually was quite, I shouldn't say unexpected, but for us, but nevertheless, we didn't anticipate it to be this burdensome psychologically. But you can see how the patient's contribution to the data is really critical in this process, and that's the personalized aspect of it. Eventually, I would say that if you follow the curve of his serial ratings, we were really starting to feel encouraged probably by month 3, where he was starting to report an overall decrease of the intensity of his symptom. He was symptomatic, nevertheless, but not at the severity that he was before. So probably around 3-4 months, as I mentioned, 6 months, he was already close to being symptom-free. So it happened somewhere in between, but it certainly wasn't immediate. Going back to a comparison with other brain stimulation that aimed to be faster or pharmacological intervention, or psychedelics for that matter, that you brought up earlier in our conversation.
How many different parts of Mike's brain are being stimulated?
We have 4 paddles that are targeting 3 to 4, and I'll clarify that in a minute, unique large-scale networks. So we have left and right, and you can imagine that the executive control network exists both on the left and the right, in the same way that the salient network and the default network exist both on the left and the right, generally speaking. And so we're using 4 paddles, but we are placing them and activating the electrode on each paddle to only specifically modulate one of the network. And so the 3 that we are after are frontopolar or executive controls. That's the lateral network that I referred to earlier. And we are accessing also the salient network. That is the network that keep track of your environment and internal homeostasis and alert you to shift attention. It's also most likely quite relevant in modulating anxiety. And the default mode network, which is that unique network of me versus you, the emotional experience of things, the internal representation of things, which is also a critical network to modulate in the context of depression. So we have this choice of network. Keep in mind that anatomy often will make it difficult for you. So it could be that the bulk of the area you want to stimulate is buried deep in the sulcus, and your electrode can only be at the bridging between the 2 gyri, right? And therefore, you may end up bleeding over and stimulating beyond that network. But we're trying very hard to be very select, because in addition to us wanting to treat the totality of the symptoms, what we are hoping from our research is that we will gain basic neuroscience knowledge about the contribution of each of those networks separately, right? And so we want to treat complementary network because that's a clinical goal. The neuroscience goal is to understand the contribution of each of those networks separately and how pushing and pulling each one of those lead to a different expression of symptoms and possibly a different result.
That was going to be my next question, because do you think that from this case study and studies like it, we are meaningfully closer to getting reliable biomarkers for depression?
You know, Alex, there's a big difference between writing a grant and getting people excited about your idea and the clarity of where you want to go, and the reality of where we are in the field right now. Certainly, yes, different brain will have different signatures, and that can be informative about what makes them unique and possibly how to best modulate it, right? But if I want to step back a little bit with TMS, which is a non-invasive way to use magnetic pulses to depolarize the first brush of cortex, so just surface of the brain, in order to lead to an antidepressant effect. I was one of the first to begin publishing about the importance of where you're stimulating in the prefrontal cortex in order to get an antidepressant effect. But the reality is most of our effort to individually target based on functional neuroimaging has been a wash, right? I mean, there's been early enthusiasm about individualized targeting for TMS, and then come studies that look at it head to head and still cannot distinguish a dramatic advantage to using individualized targeting. And this is why in my clinic, for instance, I have not instituted, we will obtain an fMRI on every single patient coming to our clinic in order to optimize their treatment, right? And so I want to be a little bit cautious about this issue of biomarker because that's a goal. We have some way to go before we can fine tune it. In the same way that we are recording from these electrodes at least in the first 4 days after surgery, when they are still in the ICU, we're able to hook up these leads to a machine so we can record the brain activity and to be able to stimulate from that machine the brain. After the 4 days, they're back to the OR, they get implanted with their RPGs, their battery, and they go home. And we're no longer getting that sensing opportunity. But in those 4 days, we also have an opportunity to start looking at the electrical signatures of either the state of depression in these different networks, or more importantly, the state of the network once you've stimulated it. And another topic of mine, and one of the colleagues that is now part of our lab with a heavy mathematics and chaos theory, nonlinear dynamic understanding of data or complex data, we've been kind of conceptually thinking about how can we take those type of conversations, electrophysiological conversation, I mean, and understand them at the complex nonlinear dynamic level. Because one of the difficulty that our field has had to deal with is the delicate song and dance between us fully appreciating that the brain is a self-organizing system, that there are nonlinear dynamics happening all the time, and us, even when we're doing EEG, we're really stretching the limit to trying to interpret something within the linear system as opposed to the chaos theory system. And so there may be complexity there. In addition, one would argue our approach is complex, right? 4 paddles, imaging, personal optimizations is certainly not a, one hat fits all. But there may be even more room for introducing yet an extra layer of complexity to understand ultimately how these neuronal ensembles manage to keep a coherent conversation. I sometimes equate the brain to this beautiful symphony and multiple instruments being played. When you're introducing a drug, and we were talking about it earlier, this idea of an exogenous compound that you're introducing into the system, in my mind, you're forcing many different instruments to play the same note.
Feels like a blunt instrument.
Right. And so it ends up reducing the complexity of that melody that you're hearing. With brain stimulation, the promise by, again, banking on the endogenous property of the system, that you could revive that complexity in a different way than what pharmacology could do. And yet I have patients that have come to me and says, I don't know what it is, but somewhere, somehow, my brain always wants to come back to the spot of feeling miserable despite anything we do. And I'm sure you heard it from your patient as well. What does that mean in terms of this attractor that is pushing this neuronal ensemble to be stuck in a very limited range of musical notes as opposed to really expanding it is I think for me the next challenge to understand and to overcome.
And what's next for the future of research specifically for PACE for this treatment?
So PACE, we have a proof of concept. We are far from saying this is a viable, available antidepressant treatment for severe treatment-resistant depression. We have to do the work. And the work is essentially building up to having a randomized control trial, which we are still prepping to get there. In the meantime, I'm not sure when this is gonna air, but we are expecting that in the next couple of days, there will be an announcement for a recent grant we have received, focusing specifically on using PACE in bipolar depression. And even more sci-fi, if you want to go back to that word, is trying to use our combined individualized targeting, intracranial brain activity recording, and the testing we're doing in the ICU to see if we could really understand what's behind mood switching from a depression to a mania. That is one of the very, very unique phenomena in the brain that we are completely in the dark about, really. We know certain things can switch you into a hypomanic manic phase, sleep deprivation maybe, or an antidepressant if you have a predisposition to bipolarity, but we don't fully understand what that constitutes really at the electrophysiological level. And so our task was going to be to do more of the brain imaging in bipolar patient to understand that biomarker profile and take a handful of those patients and get them implanted with PACE and now look at what happened when you modulate each one of those key large-scale network. Can you get to replicate that immediate switch? Could that help us truly understand the pathophysiology and the mechanism behind bipolar disorder to then develop treatment that are better informed with the true pathophysiology of the illness? So, and we're going to obviously continue to enroll a participant in our unipolar study like Mike did. We've had 2 enrolled participants so far. One has been implanted. The second one, surgery is coming up in a few weeks. And hopefully we'll keep adding to this bank of knowledge so that it can be useful to us, but also to other treatment modalities. I have no illusions that this complicated functional brain surgery is going to have massive widespread application because it's too sophisticated, it's too expensive, and is only available in complex academic centers. But the knowledge about modulating these networks could translate to non-invasive brain stimulation.
Right. So that I was going to ask about that because when I spoke to the co-founder of Flow Neuroscience, so they work very much at the other end of brain stimulation. They have headsets which use direct current stimulation, low amplitude, superficial, but has good evidence that it works. And their main question was, we need to understand who it works for and why. And so I'm imagining there can be some portability, if you like. Your research, understanding what's happening at the brain level could help inform these more superficial, non-invasive, if you like, brain stimulation treatments, perhaps.
Absolutely. At the end of the day, we're also going to start learning more what happened to these networks when you're approaching them through vagus nerve stimulation versus transcranial magnetic stimulation versus PACE versus deep brain stimulation. And there's a common pathway, or are they really completely independent in terms of how they get around doing what they do and ultimately treating depressive symptoms? So, yeah, I mean, I don't think there's a better time to be doing neuroscience and specifically advancing the field when it comes down to psychiatry and some of our key psychiatric disorders, but we certainly have the work cut out for us. The brain turned out to be a little bit more complicated than what we anticipated it to be when we declared the decade of the brain, whenever that was, in the 90s, I think.
Just before we finish, it sounds like this treatment has been of tremendous benefit to Mike. I'm wondering, has Mike experienced any side effects besides, some stress when switching between different settings? Any side effects? And how has Mike coped with this psychologically? Because I would imagine, even though his depression has gotten better, my intuition would be any big change must be a little bit weird and needs some adjusting. So firstly, side effects, and secondly, how has Mike coped with this big change in his life?
Sure. In the paper, we have described specificity of which electrode we're activating to tap into one particular network or the other. And that's really a match of the size of the paddle and, let's say, the geography of what you want to stimulate. And so if your paddle is substantially bigger, then you may want to just activate 4 of the 8 electrodes on that paddle to only be limited to that area. And so we activated in DLPFC, so on the dorsolateral prefrontal cortex, below what would be the window to modulating the executive control network. And we had Mike having difficulty expressing his words. So almost like aphasia. We've also had, in different locations, we pushed Mike into experiencing a level of internal restlessness and anxiety that made him quite uncomfortable, and we had to quiet it down. So, which speaks to the specificity of what we're doing, right? Because if everywhere we're stimulated, we got a positive response, you wouldn't want to be skeptic about it. So we've had those kind of side effects, but we clearly we stop stimulating there. And so those haven't surfaced. Mike is honestly, and I've had many research participants, he's one of those people that is remarkably eloquent and observant. And so his description of his psychological journey has been a delight to read, but even more importantly, very informative at the neuroscience level. I'll give you an example. I had mentioned that Mike had a very, very unusually looking functional neuroanatomy. His salient network seemed to have expanded so large that it expanded and occupied what should have been a node part of the executive control.
Is that what is termed in the paper cortical expansion?
Exactly.
Because I didn't know what that meant. So expansion of a particular network beyond the norm.
Exactly. And so then the other network is being encroached upon and therefore smaller. And also the functional connectivity of that network was scarce compared to what you would see in a healthy control. In the lab, when I test Mike, I'm constantly, okay, how do you feel now? How do you feel now? And he had to pause me at one point and he said, Doc, you need to understand something about me. It takes me at least a day or two for me to pick up on what's going on in my own body. Now, you and I were just talking about the salient network. You and I know that the salient network is monitoring internal homeostasis. But imagine yourself in my shoes. I'm looking at a very abnormal MRI highlighting the salient network and how dysfunctional it really looks. And I'm having the patient himself telling me I have a hard time reading my own internal signals of my own homeostasis. And they match, right? And so that's what I mean by eloquent and descriptive to the level that is really informative. To his credit, Mike never stopped going to psychotherapy or group therapy, even in the years prior to coming into our study. So he kept with that. And he came back to us and he said, I now have what it takes to implement what I've learned in psychotherapy. Before I couldn't get around actually doing it. And a couple of months ago, he who has stayed away from social gathering and isolated himself from his family, went on a road trip with a couple of his relatives and his significant other from Alaska down to Las Vegas or somewhere. And he was sending us, it wasn't a vlog actually, but he sent a couple of emails along the way, marveling at the beauty of the world that he was traveling through, and every so often pinching himself along the way saying, is that real? It is, because it has lasted close to 3 years now, or 2.5.
And there's the striking video which you posted online where you see Mike, looks like he's still in the ICU, and it looks as though he's describing experiencing positive emotions really for the first time in a long time. And I think that's what you described earlier in the conversation where you said, we could stimulate certain areas and we could start to feel good, maybe not representing an immediate remission of his depression, but we're starting to realize, okay, we can meaningfully change his psychological experience with this tool.
Yeah, and that's something for us to also understand better. And I know it has been reported with deep brain stimulation as well, where you could stimulate someone in the OR, have that experience. To what extent this immediate acute response to a stimulation translate to long-term antidepressant effect, that we don't know. The story is probably way more complicated. At a minimum, for me, the way I interpret it is that I'm in the right place. I can say that much. To what extent it predicts the antidepressant response we see at 1 year, that remains to be seen.
We'll have to find out. I will put a link to the video in the description because it's quite striking. Thank you so much for coming on and sharing this. It's been an education for me. I've had to learn a lot in a very short space of time, but I've appreciated hearing your insights. We look forward to seeing more about what PACE can bring us in terms of scientific data and meaningful improvements to people's lives. In the meantime, thank you so much for spending some time with me today.
Oh, my pleasure. And Alex, also don't underestimate the work you're doing in this particular podcast, because we often get caught in our own language, and to have someone who can translate that and make it tangible and real is part of the narrative. And so thank you for doing that as well. And thank you for inviting me.
Thank you. I appreciate that.
Bye-bye.